Hello, everyone. Welcome to our third seminar in our Health Terminology Standards and Interoperability seminar series. And today I'm joined by Dr. Laurie Block from Vancouver Coastal Health. My name is Linda Bird, and I'm the instructor for UVic's HIMP 597 course, which is hosting this seminar series. So welcome, everyone. Before we get started, let's begin with our territory acknowledgement. We would like to acknowledge and respect the Lekwungen, Songhees, and Cossepsim Esquimalt peoples on whose territory the university stands, and the Lekwungen and Wasanich people whose historical relationships with the land continue to this day. So, as I said, today is the third seminar in the series, and the topic for today is nursing data standards, landscape and directions in Canada. But before we get started, let's have a quick look at the rest of the seminar series. So next week we have Dr. David Hay from New Zealand coming to talk about HL7 structured data capture in use. The week after, we have Debbie, and Laura Lee from Alberta Health Services coming to talk about building a better health record at Alberta Health Services. And then after a 2-week break, when the students will be doing their internal presentations, Dan, Desmond, and Charlene from Connected Services British Columbia will be coming to talk about the health information standards in BC. Please note that all these sessions will be recorded and shared on the school's website. And if this seminar series interests you, then you might consider turning your interest into a qualification by enrolling in the Certificate in Health Terminology and Interoperability Standards. This is a 1-year part-time program with 4 graduate level courses, including this one, which are done through weekly online evening classes plus a virtual workshop. This is the only program in Canada that's accredited by CHIMA, the Canadian College of Health Information Management, to become a certified terminology standards specialist. So if you haven't already enrolled, you can enroll for the January entry by October the 1st. If you want to find out more, please scan the QR code or visit uvic.ca/HIMF and click on certificates. And so today I'm delighted to introduce you to Laurie Block. Dr. Laurie Block is a registered nurse and health system impact postdoctoral fellow at the Canadian Institute of Health Research with the University of British Columbia and Vancouver Coastal Health. Her emerging research focus is related to clinical informatics, computerized knowledge representation, and artificial intelligence, with a special focus on wound care, community nursing, and planetary health. So with that, I will pass the floor over to you, Laurie, to present on nursing data standards, landscape, and directions in Canada. Thank you so much for joining us, Laurie. Over to you. I'll stop sharing.
Hi, thank you. Hello, everyone. Nice to see you. And thank you for the introduction and the welcome. And I'm joining today on the traditional and ancestral lands of the Tsawwassen and Musqueam in the colonial area of Delta. If folks know the area, it's full of rivers and forests and wetlands. And so it's a privilege to be here and to present. So I'm going to share my screen today. I'll also say I'm very much an open presenter. So if you have questions along the way, please feel free to put your hand up. If you have more to contribute or different ideas, I always say I'm always learning as well. So if you have different experiences or perspectives, I invite you to share that in this hour and a half that we have together. So just if I could get a thumbs up, if folks can hear me okay and see the screen, I see a thumbs up. Thank you, Linda.
Laurie.
Okay, so again, as the noted, this is about nursing data standards and how things are looking in Canada. I will provide a very foundational, basic introduction around the topic of nursing, as well as around the topic of data standard broadly, but then we'll get really into some of the nursing specific nuances related to standardized terminologies and some of the foundational work that different organizations and leadership groups are doing in this topic area across Canada. And our objective is that hopefully by the end of this presentation, you will leave with a little bit more knowledge about the ability to identify and understand the significance of standards and data standards in nursing in Canada. But to start us off, if folks have access to the chat, could you please add in your thoughts, just initial thoughts or your own experiences? Why are data standards important, and why are they an important topic for nurses in the healthcare system broadly? I'll just open folks to share. I'm going to read out a few if folks are okay, what you respond in the chat. Or if folks want to put their hand up and share, that's okay too. I have Samir says to maintain consistency across organizations and jurisdictions, the ease of interoperability and care. Thank you. We have, they allow for common understanding of patient health experiences. Yes, thank you. To ensure consistent documentation of patient care. Well, excellent. We're all in the same room and thinking the same way. This is right. I agree. And there's a lot to say about having important representation of our data from a nursing perspective. So just very broadly, we know nurses are a significant amount of the health professionals working in Canada. And in 2023, we had just over 477,000 regulated nurses. That includes registered nurses, licensed practical nurses, registered psychiatric nurses, and they represent the largest regulated health discipline. We also know there are many concerns facing health professionals, including nurses, within the healthcare system related to health information technology. I don't think this is a surprise to folks on the line here in the topic area you're studying at UVic. But just to highlight these, we know that documentation burden is significant. And we know that increasingly in the research, this is being brought forward. We're seeing correlations between that documentation burden with emotional exhaustion and depersonalization. We know that EHRs, well, they've been in place for a few decades in many settings. We still are faced with usability issues, and that includes data redundancy, double charting, poor workflow, navigation, and difficult and cumbersome data entries. We think about sometimes seeing overcomplicated assessment forms. We see forms that are buried in 16 clicks just to get to a simple flow sheet. And these are definitely barriers and concerns for a practice. We see a significant amount of time spent on non-direct care. And so that's not, that's the kind of care or support that nurses do generally, but that number is increasing, or that time spent is increasing in non-direct patient care. Recently, a study by Wellsby et al. Demonstrated a time and motion study in acute care and found that nurses spent just over 10% of their shift on documentation. And if that ward or that unit was doing admission, that was increasing to 13.5%. We see that also echoed in a recent Canadian survey by Canada Health Infoway, where we saw that nurses' time spent searching for patient information outside of the practice, and so that could be looking for information outside of the chart even, was anywhere between 30 to 120 plus minutes. And so this is a significant issue and something that we are needing to actively address throughout healthcare. So we know that nurses create a significant amount of data. And we also know that with the global healthcare system currently in place, it is data rich with billions of data points collected daily. And these types of data are collected and include a range of topics from staffing levels to medication administration to photographs of wound, which is what I had done lots in my role in Vancouver Coastal Health, to numbers of assessments and so forth. But our ability to learn, reuse, and gain insights from these sources of big data can be complex and difficult. Therefore, researchers, clinicians, and folks like yourself are interested in finding ways that make data smart data. And smart data which is usable and actionable for application and decision making. And one of the mechanisms to support this smart transformation and use of data is through the applied use of data standards. And so again, just very briefly, there's many definitions out there, but the one that I seem to kind of fall into and think about is this one by the Canadian Institute for Health Information. Health data standards are agreed upon and documented ways of defining health-related concepts and patient information. And they really do need to be computable, understandable by both the computer and the human, replicable, reusable, and that big word, interoperable. And they need to contain those technical specifications and other precise criteria designed to be used consistently as a rule, guideline, or definition. And again, depending on the textbook or the paper or the expert, these can be broadly, this big umbrella word of data standards can be categorized a few different ways. For ease of this discussion, just for myself, broadly saying, we have data standards that fall into the privacy and security standard groupings. We have those messaging and exchange data standards. And I saw that you're going to have a FIRE presentation next week. So really exploring that topic in detail. And last week you talked about SNOMED, and so we have our terminology standards, and that's what this conversation will lean largely into, and that's thinking about how the profession of nursing is represented in these terminology standards. So when we think about our terminology standards, again, just to reiterate, we want to ensure that it's human readable and computer readable, that the terminology standard or the terminology system that's being used has really good attributes like clear concept definitions, synonyms. In my own doctoral research, I talked to nurses about how they identify wound infection, early wound infection, and I created a computerized ontology. And what was clear in that conversation was the importance of synonyms to the practice of nurses. How we describe things may have some differences in the word, the concept's the same. So having the allowance for synonyms is very important, as well as define hierarchical relationships. So the connection of words to form those relationships in context is really important. We know that terminology standards, and we'll talk about it in a minute here, can represent single or multiple health disciplines and or topics, and that they should be governed by very transparent and clear rules of how they're built and maintained and change over time. And these rules can be governed by international, national, or their own internal networks. I'll just pause right now. Are there any questions? I didn't see any hands up, so I'll keep moving otherwise. Okay, we'll keep going. And again, just to outline the high-level benefits, semantic, that meaningful exchange of information, so that semantic interoperability. This is very important for nursing. This gets back to that concern about duplication and trying to find information and accessing it from multiple sources. So really foundational to this conversation is thinking about how we can improve semantic interoperability. Of course, reporting, standardized clinical terminologies can help with reporting by aggregating data between and even within the same healthcare organization. Again, part of my role previously with Vancouver Coastal Health, a lot of it was spent in reporting, pulling out the data from our health information systems, providing it to our professional practice leaders, to our clinicians, to our point of care nurses, to help improve insights and decision-making related, in my case, to wound care. We're seeing now, and I'll talk about this at the end of the presentation, some of the advanced applications that we're seeing around nursing, as well as the integration of terminologies that represent nursing in AI applications, as an example, as well as it can be a common language for improved communication. So, kind of framing everything. We're talking about nurses, we're talking about data standards, and we're leaning into standardized clinical terminologies that represent nursing. We're going to have a look at some of the terminologies that are currently and historically existing that represent nursing. Just broadly, SNOMED CT is a large ontology, standardized clinical terminology. It's multidisciplinary. You have an expert, Dr. Linda Bird here, who I'm sure can speak much more to this area. But it has a broad range of topics, including assessments, diagnoses, interventions, outcomes, context, discipline groups. So it's a very broad, the largest standardized terminology available. In the handout that or in the lecture slides that I sent earlier, I made one typo. So make sure you go back and fix it if you read it. I said that LOINC wasn't mapped to SNOMED, and actually it is in the process. It is being mapped, and parts of it being mapped to SNOMED. So another one just for us in nursing to be aware of, we have LOINC, which is the Logical Observation Identifiers, Names, and Codes. We'll speak about those two in a minute. The other ones, we don't see too much. Actually, I'll back that up. The International Classification of Nursing Practice, we do see in Canada, or we talk about it in Canada. That one is specific to nursing diagnosis, not medical diagnosis, nursing diagnosis, interventions, and outcomes. But the others, CCC, the Clinical Care Classification System, NANDA, which is nursing diagnoses, NIC, which is nursing interventions, NOC, which is nursing outcomes, and OMAHA, which is a mix, often related to community and home care nursing. Those are largely American, but we do talk about it and may see about it in pockets in Canada. So all of those nursing terminologies is part of the problem that we face in this field of informatics. And that is because with so many options, well, which one are we to choose to represent nursing, and which one will we choose in which context? And so I want to point you to this very important document that is situating nursing informatics in Canada. And it comes from the Canadian Nursing Association and co-authored with the Canadian Nursing Informatics Association. And both associations are positioned to advance the practice of nursing. And this joint position statement has four main components or guiding principles that I want us, again, to think about throughout this conversation. The first states that nursing informatic competencies are necessary for nurses across Canada. And in fact, CASN, which is the Canadian Association of Schools of Nursing, has digital health competencies that entry to practice nurses, when they graduate from nursing school, will hopefully have had an introduction to the topic and some time spent learning about the topics of nursing informatics, including data standards, which is what we're talking about today. They also name, out of all of the terminologies listed, they name for Canadian nurses, SNOMED, CT, and ICMP are terminologies capable of representing Canadian nursing documentation. You'll notice we may use different terminologies in our practice in healthcare as nurses, but these two particular ones have been identified capable to represent our practice area. We also have standardized assessments. So standardized assessments that are usable, reusable in multiple contexts across many provinces that have been identified as good to represent nursing. We have CHOBIC, which again we'll talk about momentarily. We have the Nursing Physiologic Panel, and that is again something we'll look at. And I will call it LOINC is standardized terminology, not a standardized assessment, but it has panels and assessments embedded into it. And so they're specifically naming this Nursing Physiologic Panel, as well as the INTERI. And the INTERI, again, we'll look at momentarily, but that's a suite of assessments that many professions, including nursing, will use to support their patient care assessment and intervention planning. And finally, it talks about nursing evolution or technology evolution and how nurses will and need to be part of this emerging space. This includes thinking about robotics, telehealth, artificial intelligence, and so forth. And so just briefly, now we're going to go into some of these pieces from that CNI and CNA joint position document and kind of putting it into context and into our conversation. So the first is let's unpack, and I know you spent some time here, but let's unpack SNOMED from that nursing perspective. So SNOMED CT is the largest international multidisciplinary ontology governed by SNOMED International. As I said, it has multiple topics. So this is compared to ICNP, International Classification of Nursing Practice, which is just nursing diagnosis, nursing intervention, nursing outcome, whereas SNOMED CD is much broader, includes further discussion topics like, or axial topics, such as clinical findings, substances, context, physical forces, etc. I was just actually exploring pressure injury concepts in SNOMED CT, and with some wound care clinicians in my colleagues, and we were talking about physical forces of force and pressure and friction and shear, and thinking about how that was an important concept to our practice, and really kind of exploring how SNOMED represented those things for pressure injury prevention. We also have, again, significant amount of concepts, more than I know I could read in a day or a month or a year, 360,000 concepts with 150,000 synonyms, and that number continues to increase. Multiple translations, including Canadian French, and it's updated every month. And again, just broadly, some of those principles or those features, attributes we can see SNOMED has. And again, from my perspective in my own nursing research, it has a very good list of synonyms and multiple hierarchies. So it's connected to multiple other concepts, really improving its representation of our thinking and processing. Again, I talked about this briefly, International Classification for Nursing Practice, or ICNP. Now, what's important to note here is a few years ago in 2021, ICNP put in an agreement with SNOMED International, where SNOMED International would manage, produce, and release the distribution of ICNP, but the International Council of Nurses, or ICN, still retains the ownership and defines its content globally for the nursing profession. I'll also point out that WHO, also not only Canada, but the WHO has recognized ICNP to represent the practice of nursing. And again, just to highlight that first point, we're not talking about like my nursing assessment of a wound bed that has granulation in tissue and serosanguis exudate. No, I'm talking about more the diagnosis, the nursing diagnosis, the nursing interventions, and the outcomes, so more broader. So what I thought, and I checked with Linda before this lecture, is I thought, let's do some hands-on rather than me just speaking. If you're able to, I would love for you to join me in exploring SNOMED CT together. And we're going to actually also have a look at how ICNP is represented in SNOMED CT, if you haven't done that already. So I'm going to stop. Actually, you know what? Before I do that, I want to give you a handoff. I'm going to pretend that you and I are colleagues. I'm going to give you this patient handoff. I'm not going to go through every single piece here, but if you want to kind of take a screenshot or get a pen and paper, we're going to think about some of these concepts that are going to be in this nursing handoff. So just briefly, we're going to have this patient, Mary Green. She's 89 years old. She was admitted 5 days ago with community-acquired pneumonia. She right now is alert and orientated. She is intermittently confused at night. Her vital signs are stable. She's receiving 2 liters of oxygen via nasal cannula, and her O2 sats are 94%. She does have a productive cough. It's improving. She does have dyspnea, or shortness of breath, at rest, which is also improving. And she is afebrile and has been afebrile for the last 2 days. There's other components there about her care. But just to highlight that we're going to continue oxygen therapy and monitor the respiratory status. We're going to continue pressure. Oh, sorry, wound care nurse here. I didn't mention that I was a wound care nurse many years. She has a stage 1 pressure injury on her sacrum, so that's on the lower back. And so we're going to continue to monitor that. We're going to put in preventative care. We're going to encourage mobility. We're going to monitor her intake, output, and look for any continued signs of infection. Her family is involved in the care, and we're going to continue to monitor her. So with kind of that kind of patient story in your mind, what I would like you to do is to go into the SNOMED CT browser. And so if you Google SNOMED CT browser, it should come up, and then you're going to review and accept the terms. We're going to choose the international edition, and we're going to together kind of just explore the browser before getting into kind of the searching of topics. Linda, did folks have a chance to do that with your previous lecture?
No.
All right, let's do this together. Okay,
Mm,
the folks would it be easier if I put the URL, the website in the chat?
I think so. Yeah,
Okay,
that's a good idea.
all right. So I'll spend a few minutes then kind of orientating folks to the browser then.
Oh,
I find, at least for myself, when I was learning about standardized terminologies and myself thinking about nursing data standards, I had to get in there. I had to play. I had to kind of explore. And while it was overwhelming at first, it gets easier. And so I'm hoping that our exploration together today can provide a little bit of practical hands-on thinking around this topic.
just to clarify, the students have used the Link search tool before. They just haven't looked at nursing
Oh,
topics.
okay, perfect. Okay, well, there you go. Okay, so um, first off, let's start. If you could think about that case scenario, I want you to search for 1 or 2 topics within the browser. And I want you to see what happens, like find a topic, find a concept that might match our topic or our case scenario. And if folks are comfortable to report back what you found and your impressions. And maybe I'll put up the scenario since you've had experience using the browser. Put back up that case study. Wrong one. Oh, sorry, I'm looking at this one. There we go. This is what I'm talking about, the SNOMED browser. Wrong screen, rookie move. And there's the assessment. Nope, wrong one, I went too far. There it is. So yes, we're at the SNOMED CT browser. Find maybe a couple words or concepts from this case study, search, and then if I could have a few folks report back. Oh, thank you. Oh, we have community acquired pneumonia. Thank you. Let's look that up together. Pressure injury. Thank you. Pressure injury stage 1. Okay, let's look at this together. Community acquired, we'll start with community acquired pneumonia. Oh goodness, I can't spell. Parsimonious. Going on. Oh, I forgot the C. Sorry, folks. Okay, we have that as a disorder under the disorder axis. And so what I'm looking for when I clicked here, obviously confirming that we have the synonym, we're looking at the details. If you notice on the left-hand side, there's also an ability to filter. And so in particular, filter by ref set. So just out of curiosity, I was going to see if this particular one was part of the ICNP reference set, and it's not. It's not to say that it doesn't or couldn't be used in nursing. It's just not one of the ones that comes from ICNP. Let's look at pressure injury. Okay, I'm going to go with, I know that we have different stages, but I'm just going to go with pressure injury as a generic, as a more of a high level disorder code, and scroll down, and wow, there we are. This is a note, ICMP diagnosis. This is part of the ICMP diagnosis to SNOMED map, meaning that there's a map between or representation of ICMP with this concept. And if we go here, we can also get further details and expressions, etc. What do we have? We have oxygen therapy. Let's have a look. Oxygen therapy as a procedure, okay. Oh, we have that as an ICMP intervention. Excellent. Did I miss? Oh, increased risk for falls. Oh, falls, yes. Okay. All right. And then again, we have this within our diagnosis map. Now, while this is an interesting, I think, knowledge for you to see that, how can you look at how SNOMED CT might have different reference sets or mapped to the concepts. There's also a way to do it if you go directly into this tab for ref set, and you can just pull up. If you scroll down, we have the International Classification for Nursing Practice Diagnosis and ICMP intervention. And so we can see that there's 529 concepts that are mapped to SNOMED CT related to nursing diagnoses, as well as the interventions. And so this is a nice reference where if you open it up, pull this up, we can see a whole long list of our nursing diagnoses. So just a nice way to see how when we talk about when terminologies have been cross-mapped to each other, what does this mean to have or to find a nursing diagnosis code? This is one of the practical ways that you can do it within the SNOMED CT browser. There are others, but this is one of the ways that's really approachable for folks learning the system. Any questions? Linda, anything to add from your perspective?
No, no, it was yeah, great to see the connection between the scenario, the standard coding, and then the ICMP data sets, which they try to keep up to date since ICMP is now distributed through SNOMED CT through those reference sets. So yeah, that connection is really important. Mhm.
Great. Any other questions or comments? Okay. Well, keeping this in mind, I'll just move us back to our presentation. Okay. Okay, so we're going to now kind of conceptually shift from our standardized terminologies that represent nursing or we think about nursing into our standardized assessments. So again, recognizing LOINC is a standardized terminology, but we're going to look at that physiologic panel together. So again, similar, if you feel like following along, if you were to Google or search, again, I'll put the link in the chat. Let's have a look at the LOINC panel, the LOINC terminology. So here we can see that there are several very practical nursing physiologic assessment topics, concepts, codes. Prior to me doing informatics in wound care, I was in cardiac surgery as a nurse. Every shift, multiple times, heart rate, all the vital signs, really multiple points of documentation happening associated to this particular panel. And so again, if folks are following along, if you could think about our scenario, and I would love for you to pull out a couple of the concepts and codes that might be associated to that scenario that a nurse might be doing with that handoff. So I'll give you a few minutes to explore what kind of topics are presented on this panel. Okay, we have respiratory rate. Thank you. We have respiratory assessment. I always like this one because there's also wound care. And again, as you know of me now, I really have a passion for wound care. Any other suggestions or ideas? I can pull up, look and do respiratory rate. Let's do that one together. Oh, hemoglobin saturation with oxygen. Yes. One thing though, I will say is scrolling and finding is sometimes cumbersome. So let's look at respiratory rate. So one thing to note is if you were to drill down into this particular panel item, you can see further details, including different languages, the type of entity, members, so where else this particular item is related. I always think of this member of these panels, this particular assessment of respiratory rate is also part of these other panels. I think of that as like a beautiful thread of where interoperability could get to, like data reuse. We're reusing this one particular item through multiple assessments that might be relevant to different health professions. Maybe a respiratory therapist needs a different assessment form than a nurse. And so, but that same concept can be threaded throughout. So again, I take that as a moment of reflection and interoperability opportunities. Yeah, so you get further details. So again, just kind of bringing forward from that example what it might look like in standardized terminology, and in this particular example, a standardized assessment within that standardized terminology. And again, just acknowledging other folks. Thank you for adding. I can see your blood pressure, systolic and diastolic, that respiratory rate, so important. Thank you, everyone. Okay, back to our assignment. Also call out that here in Canada, we have PCloud, which is the Pan-Canadian LOINC Observation Code Database. Again, if you're interested in the context of LOINC in Canada, you can look at, for example, Canada Health Infoway for more information about the Canadian subset or the Canadian versioning. again, that was just this scenario of us looking together. Okay, so physiologic panel. Now let's talk about another standardized assessment called the Canadian Health Outcome for Better Information and Care, or the CHOBIC for short. So this is, again, a standardized assessment. It looks at functional status, pain, fatigue, dyspnea, nausea, falls, pressure injuries, and readiness for discharge. Several of these assessments are being informed by other assessment panels, such as the INTERI and the Sedani and Doran tool. So again, different assessment groupings, but this particular collection of assessment items that's forming the CHOBIC has been studied and evaluated and is being used in an excellent candidate to be used on admission and discharge. And it is nursing sensitive information. It has been mapped to SNOMED, CT, and ICMP. So as again, we want to think about our opportunities for interoperability and data aggregation. This is a strong candidate because this assessment has been mapped already to terminologies. And it's also cross-continuum. So it is meant to be used on admission and discharge, as the patient moves from acute to continuing care, to home care, to long-term care. And the other thing I'll point out is also kind of in this conversation of admission and discharge, you also hear about the INTERI assessment. So this is a much broader and complex assessment that's not only done on admission discharge, it can be done more frequently depending on the setting and the scenario. But INTERI is another standardized assessment, and this one again being used in multiple settings. Now, bringing it back to Canada, now this particular assessment form or assessment tool, at least here in British Columbia, has policy requirements from the BC Ministry of Health, with reporting going to the ministry as well as the Canadian Institute of Health Information. And so I just pulled out the two policy statements that are related. And so that clients that are being supported or cared for in health authorities, that if they're in the home care setting, there are particular INTERI tools that are being used for, again, certain scenarios and certain patients, as well as for health authorities supporting care for people in long-term care. So the INTERI home care is different than INTERI long-term care, for example. But they're both standardized assessments. And what makes these particular assessments interesting, again, from an informatics lens, is that it has very rigorous algorithms that support decision support. So they have outcome scales, they have collaborative action plans based on your assessment. These are the risks your patient has, so it automatically forms that kind of output. And then they have guidelines on like things that you can do from care planning perspectives to support whatever flags that your assessment decision support outcomes provided. So we're going to bring this together with, again, another scenario. So again, this is looking at CHOBIC, but just remember CHOBIC also has some of those components for INTERI, but also INTERI itself has a place in this conversation. So we're going to pretend that this person, we have a patient, they were admitted to acute care, and this is some of their, again, from a nurse to a nurse, pretend you're my nurse I'm handing off. They're admitted, they're able to walk very short distances, and they are unsteady. They have that shortness of breath, but they're able to manage breathing alone, so they don't have oxygen administered. They have swollen ankles, they have fatigue, and they're having difficulty performing ADLs, which is activities of daily living. There is some confusion about his medications. There has been a referral to OT and PT for exercise and energy management, and there is a diuretic prescribed. So based on the CHOBIC assessment done on admission, we have particular assessment scale findings. And again, this is coded, SNOMED CT coding. And so again, it could be used and reused with that perspective of interoperability. So Same patient. And now we're going to do the same CHOPIC assessment on discharge. So again, after 8 days, the shortness of breath is less. Absent at rest, but still there with moderate activity. The client is able to have the ambulation. They were assessed by physio. Fatigue is much improved, but still something to think about, and they're more easily able to complete their ADLs. There's more knowledge about medication. So again, one of the things in nursing that's really important is helping clients understand and educate and support that knowledge, especially around things like medication. So this is again a nursing sensitive indicator that we have in the CHOPIC assessment. And finally, we have the client meet with the dietitian. And so again, just comparatively between admission and discharge, we can see kind of some of the improvements. So function is improved, so 0 is better than 2. Dyspnea is improved 4 to 2. 2 is better than 4. And again, these assessment panels have guidelines in terms of how to interpret the findings. But again, we're making the point of comparing standardized assessment between admission and discharge. Okay, so now the client is going to have a home care visit. Again, you can see that the client information is present. So comparing the discharge from acute care to home care, again, just briefly, we can see that the walking is the same, dyspnea is the same, fatigue. So something's happened with the client and the fatigue has changed and the ability to manage the medication is the same. So we can see that there's a slight change with this home care admission. And again, the point being here is that we have standardized assessments that are encoded, that can be used in multiple settings across the continuum of care that represent important nursing work. It's a very good example and assessment form that can be used to support tracking longitudinally how patients are doing. Any questions so far? Okay. So all this to say, out of just out of interest, what's coming to mind? What are some considerations that are coming to mind now that we've talked through standardized nursing assessments, standardized clinical terminologies that have nursing content, the broader topic of data standards, concerns about burden, interoperability importance, aggregated reporting? What are some things that are coming to mind that they're to consider? If you were working in a health authority and Lori came to you with these great ideas, what are you going to think about with nursing terminologies and data standards? And again, you're welcome to unmute and share or put it in the chat. All right, we have using nursing specific terminologies alongside another standard terminology like SNOMED would require continuous maintenance and mapping. Yes. Thus the predicament, which also is why it's important to have that cross mapping and continued maintenance, for example, like SNOMED CT has done with ICMP. So rather than an organization having to embed both, we could do SNOMED CT and recognize that there is nursing specific content within that. Any other thoughts from folks? I'll give you another minute. Oh, we have. From public health perspective, these standards may help provide follow-up on what intervention best suits certain conditions and how best to sustain it. Absolutely. Yeah, the opportunity, and we do see that, for example, with ICD coding in some ways, and other reports that are being presented nationally, where we have health researchers and public health researchers spending much time and providing much information around about healthcare and interventions. More to come, though. I always say there's more opportunity. Well, thank you for sharing. I'll continue to read if other folks have ideas, but I'll share a few of my considerations. This is not an exhaustive list. This is just a few highlights that cross my mind. And I think, right, we talked about this. It's the complexity. Which one to use, when to use it, the knowledge required to sustain it, the staff, its implementation, and to update, and the risk of it. And so this is why it's very important for policymakers to provide a direction for health authorities and to vendors and to organizations to have the staff available, and for folks like you who are spending your time learning about this topic, that you have the supports you need if your organizations are implementing terminologies and thinking about how those terminologies are going to be used and maintained. This is a complex area. This is also something that I think a lot about, is that not everything is encoded. Not everything can be encoded in healthcare, and especially in nursing. But also that the things that are coded don't necessarily represent the full story of the healthcare system. And so this is a particular report. It's not just 2016, there's been continued versionings of it. But the quote that sticks out in my mind is, hospital harm is likely underreported, leading to an underestimate of the extent of patient safety issues. And this is coming from the Canadian Institute of Health Research and the Canadian Patient Safety Institute. If, for example, harm occurred and was recorded only in the nurse's notes, it would not be captured, as HTIS coding standards stipulate that to be coded and to be captured, therefore, in this data set, diagnoses must be documented in the chart by a physician or primary care provider. And so again, thinking about how codes are being used and operationalized at big organizations such as CIHI, which has significant power and trickle-down impact in policy, research, and practice, to ask that question of whose data is represented, whose data is not represented, and in general, what does that mean for our practice and care delivery? Again, I think about pressure injury and pressure ulcers. That's often in the role and scope of nursing. And so unless a provider is putting that specific code in the discharge abstract database, the DAD report, and it's coded specifically like for an ICD code, it may not be collected or captured. And that's an important patient risk and quality care indicator that, as reported here, is not being captured and reported out to Canadians. And again, representation and completeness. So again, I think about with these terminologies, again, while this tweet is from a few years ago and it's specific to ICD with the International Classification of Diseases, it still is striking. And it brings the point about that what happens when terminology standards or codes are used to represent particular clinical groups or settings when we know itself has limitations and the code itself may not be representative or can't represent what we're trying to describe or what we are describing in healthcare. And so some of the work that I've had the privilege to do is to work on evaluating our terminologies for representation of nursing. And so some of the work we've looked at is the visibility of community nursing. The first article there was with the HTIS, it's the International Classification of Health Intervention, so that's by the World Health Organization. And things at the time of mapping, there was nothing related to medical assistance in death, for example. There was significant gaps in community care and nursing. And so again, working with these organizations to ensure that they improve and increase the representation of what we're trying to present and inform related to our practice. The other one there, again, was just looking at wound care and looking at how it was represented in particular at SNOMED CT. But all of this to say there's so much opportunity, and this is what excites me and what I love about this field. We know that data standards for nurses and to represent nursing has the significant potential, and it does do this work. So the use of standardized clinical terminologies to measure and support nursing care, yes, it is emerging. Yes, there's still work to happen, but these impacts include knowledge related to the relationship. So one of the things we're starting to see with the use of these terminologies is a relationship between the number of nursing diagnosis codes and hospital length of stay. So a few years ago, there was a study put out by Inori and colleagues. So this was in the US, they used NANDA. But what they looked at was that for every additional NANDA nursing diagnosis, a patient's length of stay was linked to an increase of 0.59 days. So that makes sense, right? The more nursing kind of diagnosis codes entered could be a proxy for more complexity. And so that has real impact to health operations, looking at length of stay and, of course, patient outcome. Other things that we're excited about in this topic area is looking at workload insights. Again, a few years ago, Bettaracci and colleagues did a systematic review and meta-analysis, so a big scan of looking at how people were using nursing diagnosis codes. And what they saw in acute care, medical and surgical units was that the use of nursing diagnosis codes were being predictive indicators for nursing workload. Again, more nursing diagnosis codes, more workload. And in home health, that increase was looking at predictive for that length of stay of home visits. So not just acute care, but we're looking at home health as well. And finally, also in that big meta-analysis review, those researchers were reporting on evidence of significant improvements in physiologic and clinical outcomes, so patient care, when nursing-related terminologies were used to support communication and documentation. So for example, they found that there was improved outcomes related to glycemic control, incontinence, quality of life, pain, and post-op complications. And so while there's still limitations existing and still the need for more research in this field, we are seeing that this evidence is helping recognize and to represent and to support the practice in the field of nursing. And here is a topic that I'm particularly interested today in, and this is what my postdoc research is looking at in particular, is looking at how standardized terminologies and artificial intelligence may work together. And so there is emerging a new work happening right now. Some interesting work that's happened looking at RAG, or support retrieval augmented generation pipeline. So the work that helps with data pre-processing related to large language models and natural language processing. So this particular study looked at combining NANDA, so again, American, NOC and NEC terminologies with large language models. And so the vector database, or the ability to extract topics, was improved, and generative reasoning was improved when they integrated those standardized terminologies in with the large language models. And what they found was that there was some improved precision in what the large language model was able to extract from free text, in this case, care plans, I believe it was. Yeah, free text care plans. So improved reasoning and precision of the summary of extracting what was coming out from those care plans. And in their example, they also noted that those clinicians were having to manually add to their EHR those particular nursing intervention codes. That was improved because they didn't have to do as much manual entry because the extraction was providing it for them. And we also see it in other forms, such as natural language processing, again, by proxy of having these standardized terminologies with synonyms, with relationships, with hierarchies. Those can be used to support feature selection, topic modeling, and training with synonyms for these particular NLP protocols. So again, lots on the horizon. Very exciting to see how data standards are being integrated and applied in artificial intelligence settings. And finally, exciting opportunities are the initiatives happening throughout Canada. And so since 2016, there has been work with the National Nursing Data Standards Symposium. And this is where nursing leaders from across Canada have gathered, where they discuss and they action, looking to create a vision and strategy for nursing data standards. We have our Canadian Nurses Association and the Canadian Health Infoway. So recently in April of 2026, leaders met, I think it was in Toronto, might have been Ottawa, but they met in Ontario, and they were looking at how CHOBIC could be implemented broadly. And they're looking at creating some demonstration projects throughout Canada. CIHI is also exploring how we might be using components from the CHOBIC to add to the DAD, the Discharge Abstract Database. So again, how we're adding different nursing sensitive indicators to something that has historically been centered around providers. And then finally, looking at how Bill S5, have you had a chance to discuss the newest connected care bill, Linda?
It's been raised by some previous speakers, but only briefly touched on.
Excellent. So yes, so with that important work of Bill S5 connected care going forward through the House and Senate, we know that it's a bill that doesn't have everything. And so one of the recommendations that nurse leaders are putting forward is the recommendation for healthcare organizations to adopt the collection of standardized clinical data, where that bill doesn't explicitly call that out. And so there is some briefing notes being prepared as we speak to be delivered on that topic. All this to say, we know for certain for nursing data standards to thrive, to continue to support care delivery, we know that leadership and clinician engagement are essential. They are key. We know that partnerships, and so partnerships with organizations such as the Canadian Nurses Association, the Canadian Nursing Informatics Association, with Infoway, with Digital Health Canada, with again, the broad network of communities, with universities, with organizations, again, is essential. And that there has to be consistent and continuous communication, things that we can improve on, that we can continue to voice is a value proposition and benefits, how important this is to the delivery of care, to the importance of healthcare providers and to organizations. And so with that, I was a little bit quicker than I anticipated, but I would love to open it up and ask, what are your reflections? What are your thoughts? Maybe you can tell me a little bit about your backgrounds and how this topic might be impacting your role or your future roles. Maybe I'll stop share so I can see faces if you want.